Welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have with me a great guest, Jasmine Brown. So, Jasmine is from the great state of Maryland, where she spent most of her childhood. She was born into a military family, go Navy. She attended the University of Maryland Eastern Shore, a historically Black college or university, and graduated Summa Cum Laude with a Bachelor's of Science in Exercise Science. Then she furthered her studies by obtaining a Master's of Physician Assistant Studies in June 2021 from the University of Florida. She has been employed with the Department of Urology for 2.5 years. Ms. Brown has a passion for health disparities and proper education of patients to empower them to make knowledge-based decisions. She's active in the education of upcoming medical professionals and serves as an alum interviewer for UF School of Physician Assistant Studies. Her responsibilities include care of a multiple of urological conditions, but specializes in oncology and female urology. She additionally enjoys, besides assisting in the operator room for robotic surgical cases. So Jasmine, thank you so much for being here with me today.
It's a pleasure. Thanks for having me.
Absolutely. So you want to tell us a little bit about your role and were you always planning to do this?
Yeah, sure. So my role as an advanced practice provider or physician assistant is I provide care. So I'm able to see patients on my own. I can prescribe medications. I can refer them. I can do assessments and plans. So I do clinics on my own, but also work in combination with a lot of the oncology surgeons. And then I also assist in the operating room with robotic surgeries 1 day a week. I love assisting and I also love being in clinic. Did I always plan on doing this? No. So when I started PA school, I thought I was going to work in urgent care and I was going to go back to Maryland. And I never thought I would like surgery. And surgery was my very last rotation of PA school. And I actually ended up liking it a lot. I just knew that I didn't want to do it every single day. And then when I applied to urology, it was kind of like a wild card. I never thought I would go into it. I did always like OBGYN or women's health, and I have a component of that in urology, but I always knew I wanted to work with health disparities. And so with prostate cancer, it affects Black men. If they have the worst outcomes, they're more likely to be diagnosed with prostate cancer. So I kind of found my home there.
Great. Well, I'm so glad you did. Like I mentioned before we started the interview, we have this thing called Cancer Connection here at UF, where we have great speakers every month. And that's when I was really heard you speaking and educating us about prostate cancer. And I was like, oh, what a perfect guest. So you can educate my audience. So again, thank you for doing this. What do you think should be the expectation from a patient after a prostatectomy surgery?
Yeah, so when we educate patients on a prostatectomy, a few things we tell them. It is a major surgery, so you should expect to be a little bit limited in your activities to allow yourself to heal. We do perform prostate surgeries robotically, which has greatly decreased the amount of time that patients need to be in the hospital and allow them to go home. We actually have one surgeon where if their patient's a good candidate, they go home the same day. So really just managing expectations to know that you did undergo a major surgery. Another thing you should expect immediately after surgery is to have a Foley catheter. And that's really just to allow your kind of bladder neck and where your urethra, which is the tube that kind of connects the bladder to the outside, and the actual neck of the bladder to heal, because they completely reconstruct that during surgery. A few other expectations: erectile dysfunction. So we tell patients that no matter how good or bad their erections are, they should expect it to be worse after surgery. And that is really going to vary on something we call a nerve spare. So if you have prostate cancer that is pretty advanced and kind of invading the edges of the prostate, the doctor or the surgeon is going to more than likely try to cut through the nerves a little bit to make sure they get all the cancer. So it's really just going to vary on how aggressive the cancer is, or the grade of it, Gleason score, and where it's located. And the last thing we tell people is usually stress urinary incontinence. I like to tell my men that their whole life, they use their prostate like a stopper in the sink to control their urination. And all of a sudden we take that stopper away and they have to learn how to use their pelvic floor muscles to control when they're peeing and make sure that they're not leaking on themselves. So those are the major expectations.
I love that sentence that you tell them. I think that really is a good way for them to realize, I have pelvic floor, because so many times is I think that women have been listen more to that concept of a pelvic floor, right? Because it's more natural for women as we get older to leak, right? Which that's it's not natural about it. And everyone who listens to this, you shouldn't have to deal with that, right? That's why we do physical therapy for pelvic health and to try to really help with that pelvic floor to avoid that, because you shouldn't, no matter what age you are, that shouldn't be happening. At least some dysfunction is happening, right, on the organ, or just those muscles being weak, like any other muscle in the body. So for men, that has never an issue, right? Because it's supposed to be, no, I'm the man and I will never have any issues with that, right? So I'm sure that it is a lot harder for them to really come to like leaking and erectile dysfunction, which I'll kind of ask you a little bit about that. But yes, that's a good way that you guys explain that to them. Will you be able to give 3 valuable tips for the cancer with patients who have a prostate cancer?
Yeah, so I kind of answer this. I can give 2 answers because when I first read this, I kind of thought about like post-prostatectomy or any kind of post-procedural for prostate cancer. But I said one would be to, give yourself grace. I think it can be frustrating for patients, that essentially they go to sleep and they wake up completely changed, forever. So we know that it's been hours of surgery, but for them, they've just been out. So it can be very frustrating to adjust to all the changes, and some of them feel frustrated because it can be months of putting in work. So the next one I had was consistency. So especially with like the urinary incontinence, I tell patients that just like when they go to the gym, consistency is key. So if you're constantly working those muscles, the stronger it's going to get. When you kind of lax off on those muscles and those exercises, they're going to get weaker and you could experience more leakage. So telling them that be consistent. I love to tell my patients commercial breaks and car rides, you have nothing else to do your pelvic floor exercises. And then patience with the process of healing, patience with your providers, because we are on your team and we're going to work with you to get the outcomes that you want, but we also want you to also put in the work on your part, would be the 3 biggest ones that I would give. And I think those can apply just general cancer as well, because I think a lot of patients, I work with bladder cancer and other cancers as well. It's just can be very frustrating experience. And it just, you have to, your body is trying to fight a fight, and we're trying to give it the tools that it needs to fight that fight. So you just have to be patient, and I would add to be in a way inquisitive, ask questions, be a part of your care,
Yep.
Do your research, ask your providers for trusted resources, because Dr. Google is the worst.
Yep,
Um, do not
absolutely.
use Dr. Google. Ask for trusted ones. If you don't understand something, ask again. Come to your appointments with a notebook of the questions that you have, so that when we ask you, we really want you to ask us questions. It's not an empty, like back in the thing when we say like, hey, what questions do you have? And a lot of my patients say, well, I can't think of none. I had a whole bunch, but then I got here and I forgot. And it's so bring that notebook. I'm not intimidated at all by a wife of a patient, a spouse of a patient, or a patient coming in with a notebook of questions. It makes me realize that you're engaged in your care.
Yeah, that's very good advice. And again, sometimes part of it is you get hit with a cancer diagnosis. So the word cancer is huge, right? And no matter what it is and how good outcome or not, your mind goes to, I'm gonna die.
Yeah.
Who's going to take care of my family, and how much longer do I have? And your mind just go there versus like, okay, let's just make a step down and see what's next, right? So it's really take you into, and then you guys are like the first person they see, right? So you're the entry to it. So everything is so fresh, because even happened to me when I see patients and they come to us after they have seen you guys, and then they still like, so your doctor explained ABC, and they're like, no, not really, and I'm sure you guys did, but in their brain, they only capture a little bit of it. So great idea to just write all those questions, if you happen to come across a physician who are telling you, well, I really don't have those answers, or no, those are not really pertinent questions, you better find somebody else, right? Because if you don't want to have you don't want to have a physician who is not willing to really work with you, and you should be the huge part of, you're the CEO of your team, you're the CEO of your body.
Yeah.
Super important to get that going in there. What should be the expectations from the patient? I'm sorry, like, what would you address your patients in regarding their bladder, bowel, or sexual function?
Yeah, so I'll start with the bladders. Again, right after surgery, then you'll have a catheter, and usually about a week later, you come into clinic and you're going to see one of us extenders, and we're going to do something called a trial of void, where we fill your bladder up through the catheter and we take it out to see how you pee. Um, so that's the first thing. So the catheter expectation. We usually tell patients that about 6 months after surgery, 70% of men are dry. About 1 year, 90% of men are dry. And we also say for that 10% that maybe aren't dry, we do have other options, so that men don't feel hopeless or feel like, oh my goodness, if I'm not dry, I'm just stuck this way. There are plenty of other options. We also see patients after radiation. It's rare, but sometimes they can have something called radiation cystitis, which is kind of presents most like a UTI, where it's burning with urination, frequent urination, maybe some blood in the urine, because the bladder is just very irritated from the radiation that they received. And for that, a lot of times, if they're having active bleeding that we visualize on a procedure called a cystoscopy, we can send them to hyperbaric oxygen to help heal. There are options. There's times where we take people to the OR if they're actively bleeding from one site, and they can something called fulgurate it or kind of burn it so that it stops bleeding as much. So those are more rare. I think the biggest one, especially from our department, is going to be that leakage. Erectile function, again, kind of goes back to the nerve spare. You should always consider that. For a lot of men, we put them on a low dose Cialis or tadalafil, and that basically is just to promote blood flow for the first few months. You shouldn't be expecting to get a full erection from that. And then we kind of work within this, usually the immediate post-op visit, we don't address erections too much, just to confirm that maybe they're taking the Cialis. Usually a few months after that, we start asking about, are you getting any kind of spontaneous erections? If not, we give it a few months, because I like to tell my patients, if they ever had any teeth surgery, nerves really don't like being bothered, and it takes them a while to kind of get back in their groove. And it's the same with nerves all over the body. So usually at 6 months, if they're not having spontaneous erections or some erections, that's when we start kind of trying different medications, or we can teach men to inject directly into the penis to have erections. And then the last state resort would be like a penile prosthesis. When bowel function, a lot of times it's more so related to anesthesia. Radiation has more of the side effect of bowel symptoms than surgery. It's rare for us to invade into the rectum, but usually our education is that after anesthesia, you could be constipated. So especially at the first post-operative visit, that's a week after surgery, we're checking to make sure, have you had a bowel movement? Are you passing gas? If not, we need to get you on something, because you should be doing that.
That was great. How about any limitations for physical activity and return to any exercise program after a prostatectomy? Sometimes we have some mix, and again, is every surgeon has their little own protocol, but we hear a little mix of like, oh no, just 2 weeks and you can get back, or sometimes no, wait 6 weeks. So what are your thoughts on that?
Yeah, so it's a gradual approach in general. So maybe that's why patients get a little confused. So, of course, a lot of times for their post-operative appointment 1 week after, we try to coordinate with pelvic floor therapy. So, the appointment for their first session would be then. A lot of times we tell patients that you can sweep the floor, but you can't use the dustpan to pick anything up. So, you really want to limit your bending because every time you bend, you change the pressure in your abdomen. And even as the external incisions or the cuts that they made are healing, it still takes quite a while for you to heal internally. So I try to explain that to patients. I had one patient, he was asking, when can you go swimming? And I had to explain to him, like, you don't realize how much you use your core to swim. I wouldn't recommend it. You need to heal. And I'd hate for it to kind of put you back. So again, that's where that previous statement, patience, it's going to take a little bit before you get back to your normal routine. So no greater than 5 pounds, usually for the first couple weeks. We don't allow them to drive for 2 weeks. Walking is always encouraged. So I tell patients that you can walk as much as you want. Again, we want you limiting bending and anything that's going to change that pressure. If they're having any increased pain, for my patients that are a little heavier, I oftentimes recommend an abdominal binder while
Mhm.
they heal, just because it can put a lot of stress on those incisions,
Mhm.
especially if you're moving around. Sometimes if the surgery is doing during like kind of cold season, abdominal binder is great if you have a cough, because every time you cough, one, you're going to probably leak, which is going to be annoying. But also you're going to change that pressure in your abdomen, and that could really have a negative impact on those incisions. And then I say, depending on age at baseline and your functional status, it can take anywhere from 3 months to 6 months for you to feel relatively normal. For my older gentleman that maybe isn't as active, it might take quite a bit for him to feel like I'm back to my normal self. For my gentleman that is very, very active, it might be quicker, and that's why it's important. A lot of times we ask patients if they are obese or overweight to try and lose weight before surgery, to try to have some kind of activity beforehand, because it's really just going to have a positive impact on the healing process.
So you think that sometimes, for instance, for some of our breast cancer patients, we tell them, no more than 10 pounds in the first month for lifting, but you can walk and you can do other things. Do you think that you say 5 pounds, like what, 2 weeks, 4 weeks?
Yeah, I usually say 5 pounds for the first 2 weeks, and then you can try 10 pounds. And we always tell people to be listen to your body. Your body is a great tool to tell you when you've done too much and you're tired. And if you feel that, then you scale it back. You don't overdo it, you don't push through. And you take that time. But our general one is no more than 5 pounds, or a jug of milk for first 2 weeks. You can slowly start increasing to 10 pounds over the next couple of weeks, and then you can slowly start increasing after that.
Okay. How about for some of the more athletes type of patients who are like runners or more, that kind of impact like that? What will be your advice?
Yeah, it would be the same, encouraging walking, not running, because again, running, you don't realize. I feel for a lot of patients, they just don't realize how much you use so much of your body to do what seems like simple task.
Mhm.
It's kind of like an example. I broke a toe last year, and I didn't realize how much one toe had an effect on every step you take,
Yeah.
because your foot curves, and your body is just an amazing machine, and everything has an effect. So you really just have to take it slow and be patient with yourself to really, it's better to go slower than to speed along, injure yourself, hurt yourself, and then have to kind of scale it back.
Got you, got you. So again, you're thinking full for this athlete that is a runner, like maybe an average of like you think 3 months, 4 months to get back and do into the running if they have
I
it.
would say at least 10 weeks to 12
Okay.
weeks. Yeah.
Okay, got you. Okay, perfect. Thank you for that. So you mentioned that you tried to set up the appointment for pelvic floor therapy about like a week. So this is pretty much a standard. You refer everyone to pelvic floor therapy?
I think most, if not all, our kind of our standard is if someone's getting signed up for surgery, so prostate surgery, the surgeon is placing a referral to pelvic floor therapy at the exact same moment. And a lot of them have built it into their like order set that when they put in the orders for the surgery, automatically populated is a referral to pelvic floor therapy.
Yes, and we have seen that, and with that, that works so great. I think that seeing a patient pre-op is an amazing thing just for many reasons. One, again, we can help with that education, right? We can help to really um, re-emphasize what you guys has been explaining about all this potential. We can know what are your pelvic floor now, so we can compare how is but after, right? Because if you already have issues, and then you're going to go through this surgery, the expectation is you're not going to be back to normal because your normal wasn't your normal, right? You already have some
Yeah.
dysfunctions with it. So that always work. And I think the piece of education is super important because we tell these patients, please make sure you see us after surgery so we can look and see and we can compare. And the more we can start activating things, you
Yes.
the faster your recovery is going to be. And hopefully start, again, I don't know what is the average time between diagnose and actually surgery time, but sometimes that can be even 4 weeks. And in those 4 weeks, if you can start already to work out and start doing something to manage your weight and to become more into a healthy habit to do some other activity, that's way better to do it before you start to now having to deal with the pain from surgery, right? So the more we can engage them into that, the better. So we really appreciate that. How can people find you?
Yeah, I apologize on my patients. I'm difficult to find. I'm actually not that active on social media. But I tell obviously I'm all usually in clinic every day except Friday unless I'm out of town. But my work email is jbro0017@shans.ufl.edu. So that's probably the best way to reach me as regards to a patient.
Perfect. And I will add that to the note show so patients can find you that way. What will be a painful lesson that you learn along the way, either from yourself or from just working with this patient population?
Yeah, I would say it's always better to over-educate a patient or to assume that they don't know than assume that they are familiar with the information. I've had a couple instances where maybe I used the wrong language or I used too much of medical jargon and patient completely missed it and misunderstood. And I think sometimes that can influence their decisions for treatment as well. Whether it be that they instead opt for radiation. I generally say that, younger healthy patients usually do much better with surgery than radiation, just because radiation, the symptoms that could potentially arise are going to be when they're still viable and kind of lively. So like a 60-year-old at 70, the hope is that they're still doing really well and have a lot of life left. For my 85-year-old patient that's diagnosed and then wants treatment, then radiation could be a great option because they're going to have more complications with anesthesia. So taking all in those plays, I just think it's super important to educate. So for my um, patient encounters when they come in for office visit, and let's say it's post prostate biopsy and they have cancer, I really try to take time to write down everything I say to them on a sheet of paper that they could take home. I used to do it on like the table sheet just because it was bigger, but then I was like, well, they leave this here. So I started actually putting it on the back of the pathology. So because one, if they come by themselves, I know that their families or their loved ones are going to have questions and they get to show them, oh, this is what she said. Another one, I started sending, me and an older surgeon did a talk on YouTube a few years ago. So I always send that and I tell them, hey, this video is an hour and a half long. It's so much more than I can give you in 30 minutes. So just giving them resources and again, over educating them is always going to be better. If they stop me and say, I know all that, great, but it's better to be stopped for me and someone tell me that than me to assume the other way. And then I feel like it just really negatively impacts their care.
Okay, great. What are good resources for patients to use to educate themselves? You mentioned don't use Dr. Google, and I'm totally agree with that. So what good resources do you think?
Yeah, so I would say definitely if it's gonna be a provider, whether it's a physical therapist, an MD, a PA, a APRN, I think you have to be very careful to not watch too many like YouTube videos because a lot of times it can just be opinions and people can form those opinions based off of them alone. And there'd be so many more facts that are missing. For example, I have patients that come in and they say, well, my friend got this treatment, this is what I want. And it's like, well, you don't have the exact same diagnosis as your friend, whether it's my friend got focal therapy, which is an option if they have cancer very localized in one area. But if he has cancer everywhere all over the prostate, we can't do focal therapy. So really having that sit down conversation with a provider. There is one book that's been around for a while. It says Dr. Patrick Walsh's Guide to Surviving Prostate Cancer. I think that's generally a good resource. I would focus more on kind of one, if it is medical professional, like I said before, but also you have Cancer Connections. We give webinars, very educational, objective resources are going to be the best.
Very good. Excellent. What is one question you wish I will have asked you and you will have answered it?
Yeah. So one question I thought of was, what do I love or enjoy about my job? I would say I really love being a part of something greater than myself. I think I'm pretty altruistic that way. I get to partner with patients during difficult seasons of their lives to encourage them and to really just, my goal is to provide quality, compassionate care. And sometimes it can be in the final months of their lives. I used to think that I could never work with cancer because I was too empathetic, but through working with it, I actually realized that that was kind of my superpower because I think those patients, they need that compassion and that empathy in those moments. So I love it. I love building those connections. I love being, the difference. Sometimes patient comes in in the past they've seen other providers at other institutions or whatever you have you, and they're very frustrated and not understanding, and me sitting down with them and going through it with them and then realizing like, oh, okay, this can make sense to me. So those are some of the things that I love about it.
That's awesome. And I'm so glad, sometimes um, we just, again, yes, we're providers. And I don't think I have met anyone who treat oncology uh, who don't love what we do. I think that sometimes you hear more physicians or any kind of healthcare providers burn out in other type of specialties.
Yeah.
I think with us, it's just amazing how grateful these patients are. So I
Yeah.
think that that's what makes the magic. I think that you just, you do something a little bit for them and they feel so much better and they're just so grateful because I think that when you go in through a cancer diagnosis, you just see life a little bit different, right? So the small, you just don't sweat the smallest stuff, right? The bigger
Yeah.
stuff is what matters. So that's what at least has been making me so passionate about this oncology, right? I used to do, ortho and sports medicine and definitely is not, again, I make a lot of changes in many people's lives, but it's different when it's about oncology. It is that definitely, I've been learned so much from each one of the patients I have seen all along, but so I think that this is a great motivation for us just to continue seeing them, and we just really drive to improve ourselves and improve the resources and hopefully do research and see what else can we do to try to help quality of life. So it's not just a matter of like, we're just going to take care of the cancer, but we got to be taking care of you as a human being. And how can we make life easier instead of just throwing all these treatments and make your life miserable, right? Because then, yes, you don't have cancer, but you have all these other issues from it. So I think we are becoming more and more about being such a patient-centered type of institution, which we always have, but I think I've seen that more and more, at least in our institution and in general. So perfect. Thank you so much, Jasmine, for doing this. I
You're
really enjoyed
welcome.
this conversation. So I'm sure that the audience as well enjoyed it a lot. So you really give us great information. I really appreciate it.
Thank you. It was a joy to be here. And again, you show list the email, but you can reach out to me with any questions. But thanks so much for having me.
Absolutely. So you have a great rest of the evening, okay?
Thank you. Bye.